Thank you for joining us today. I want to welcome everyone to the second installment in STS's 2021 Webinar Series. This series runs every month and features presentations and panel discussions on a variety of topics relevant and important to CT surgeons and the world of CT surgery. The topic for today's session is high-impact studies in cardiac surgery, key takeaways. We want to make this webinar as interactive as possible and hear from you, the audience. To this end, you may utilize the chat feature and enter questions through the Q&A feature in Zoom. The panelists will try to respond to as many questions as possible. Please note this webinar is being recorded and will be available tomorrow morning on the STS website, STS YouTube channel, and the STS Surgical Hot Topics podcast. At this time, I'm pleased to welcome our moderator for this session, Dr. Joe Bavaria. Dr. Bavaria is the Vice Chief of Cardiovascular Surgery and Director of Thoracic Aortic Surgery at the University of Pennsylvania. Dr. Bavaria, let me turn it over to you to introduce our panel.
Hello, everybody. I would like to introduce our panel. Welcome to this first, what really is just a review of some key clinical trials. Our panel is quite outstanding and distinguished. We have Dr. Anyanwu from is a professor of surgery at Sinai, mitral surgeon and all-around very smart guy. Steve Bolling from the University of Michigan, professor of surgery there, mitral surgeon extraordinaire and an accomplished innovator in the cardiac surgical space. David Fullerton, past president of the STS and now the executive director of the ABTS, and an expert on TAVR as well as Ischemia and XL Trials. Katherine Harrington, a structural heart and aortic surgeon from Baylor Scott White in Dallas, Texas. Mark Rule, chief of cardiac surgery at the Ottawa Heart Institute in Canada, and an expert in Ischemia and XL Trials, as well as an editor of Circulation. And Vino Tarani, a chief of cardiac surgery at Piedmont Heart Institute in Atlanta, is a professor at Georgia Tech, and on the executive committees of both the STS and, importantly, the partner family of clinical trials. And lastly, introducing Pavan Atluri, who's chief of transplant VAD at Penn, as well as a mitral surgeon and chair, importantly, of the STS Adult Cardiac Surgery Workforce, which is the sponsoring workforce of this webinar. Pavan, would you like to say a few words?
Yes, thank you, Joe. And thank you for all of you for joining us on this, what hopes to be a very exciting webinar. On behalf of the workforce on adult cardiac surgery, I would like to welcome you all to this webinar series. Our hope with this series is that we are able to digest and break down many of the key papers that have been released in our field and give you key takeaways and key points on how these findings and these papers influence practice and hopefully make it more relevant to your day-to-day practices. So with that, I'll hand it back to Joe.
Thank you, Pavan. So this is just a journal club. It's going to be a freewheeling exercise, and we're going to speak about 4 big trials covering, what we do every day for a living. So our first trial, Wesley, if you can give me the slide. So our first discussion is going to be on the Ischemia trial and the coronary bypassing in general. This was first presented by Judith Hochman at the AHA in Philadelphia about a year and a half ago. Next slide. And then was published just recently in the New England Journal of Medicine about 1 year ago. Next slide. And if to summarize, and I'll have our experts comment on this. This was a trial at 320 sites in 37 countries. The 5,200 patients. The mean age of entry was about 64, most of them male. A lot of diabetics, about 42%. And had an average follow-up of 3.2 years, but out to 5 years. And what it was really looking at was an invasive strategy versus a conservative strategy, and looked at a primary outcome of composite of CV death, myocardial infarction, or hospitalization for angina, CHF, or cardiac arrest. So with that, next slide. So for everybody on the trial, on the line, what does the Ischemia trial mean for us? What do these results mean for us as cardiovascular surgeons? Next slide. So this is a kind of a caveat slide that I put together, or actually Mark Rule put together, that I wanted to put up. Mark, why don't you tell us a little bit about what this slide means and what the Ischemia trial means to you?
Well, thank you, Joe, and thanks for the invitation. I think it's really important that surgeons understand the Ischemia trial, because you can't really have a heart team discussion without being well aware of what the trial is about and what its caveats are. It's not a trial that compared to revascularization versus medical therapy. We have many of those going back to the classic Lancet Selim Yusuf meta-analysis that was published in 1994 that essentially established the modern indications for CABG. So ischemia did not compare revascularization to medical therapy, and even less did it compare CABG to medical therapy. Although the lay press and many people who don't really understand the trial will try to make you believe that it did. There was actually a New York Times headlines going about ischemia and saying surgery for blocked arteries is often unwarranted, researchers find. So that is totally the wrong conclusion. Let's go back a little bit to the basis of ischemia. So there was an initial invasive strategy group, and there was an initial conservative group. So that's just the initial strategy. In the invasive group, more people got medical therapy alone than actually received bypass surgery, 21% versus 20%, and about 60% received PCI. However, I think one can state that CABG was underutilized, because there was actually 71% of patients in that group who had multivessel CAD, and about 42% who had diabetes. So I think it's fair to say, although this was left to the local heart team to determine what they would get, medical therapy, PCI versus CABG, I think it's safe to say that CABG was grossly underutilized. Therefore, the conclusion should not be more than what the paper is about, what the trial is about, which is a strategy of waiting to perform angiography in patients with moderate to severe ischemia is as good as proceeding right away with it at 3.2 years, and that's it. It's not revascularization not being as good as optimal medical therapy.
Very, very good. David, do you have any comments? David, you're on mute.
Yeah, thank you. Thanks, Joe. I can only echo the points that Mark has made. And it's important, to understand, as Mark has pointed out, that in the kind of aggressive strategy, if you will, the vast majority of those people got PCI. And whether or not they should have gotten CABG instead is unknown. And so right off the bat, I think that's a significant limitation to the study. The other thing to be aware of is, as we as surgeons look at all of these trials, whether we like it or not, it's important to pay attention to the definition of procedural MI, because that definition changes from one study to the next. And in the vast majority of these trials, that definition is going to determine a significant difference from one group to the next. And yet, if you change the definition, the results look very different. So it's important to pay attention to that as we look at any of these trials going forward.
I'd like to come back to that a little bit, David. Before we go to Vino with his hand up, can we go to the next slide, please? Okay, so this is the central illustration of the ischemia trial, just for the audience to be able to focus on. Vino, what are your thoughts?
So, I agree with what Mark, first of all, Joe and Pavan, it's a great idea to do this. Thank you so much for inviting us. I agree with what Mark and David have said, and, I'm not sure how this has affected cardiac surgery nearly as much as it has cardiac for cardiology, because we weren't getting some of these patients, they were going to PCIs, and I think that there's maybe a trickle down effect for us, but it hasn't affected my personal practice as much. And I'm interested in if we've seen any fallout from this from the other guys that are doing coronary surgery or from Katherine. But from this, you look at this and you start to think, the crossover, Joe, that we've seen for everything is around 3 years. And here we're seeing that crossover at 3 years for conservative strategies, with having, even though it's not significant at 0.3, you start to see that maybe at 10 years it will. And you can see the cumulative incidence of other primary composite outcomes is starting to grow after about 2.5 years here or so. So we're seeing this over and over again. But, one question I had from Mark and David is that's coronary angiography. A lot of our stuff now is being done by CT. And is this, can you take that same perception that you have for coronary that you do for CT now, which is a little bit less invasive as coronary angiography. Do you believe those results hold up the same for running somebody through a scanner versus an angiogram?
That's a great question, Vino. And I think that data is coming out. I know without revealing anything more that the sub-studies are happening with regards to the extent of plaque, the extent of the stenosis on CT versus the actual amount of ischemia on non-invasive imaging. So I think there's a lot to soon come our way with regards to that. And your point is very well taken. I just want to add, I think it's important to know about ischemia. I don't think we should dismiss it. I'm not even sure that these curves are going to separate at 5 years, because let's remember the long-term data of Courage, of Berry 2D, of Fame 2. Essentially, it's very hard to show an advantage for PCI over medical therapy in stable ischemic heart disease, and even less so in patients with diabetes. And 42% of patients in ischemia had diabetes, and 71% had multivessel disease. So I would have expected at least 40% of these patients to have received CABG, yet the proportion was only 20%. So we have to make sure that this does not invalidate the well-established indications for CABG that our patients benefit from, and yet it doesn't lead to missed opportunities to save lives.
Yeah.
Just to, sorry.
Ani, go ahead, please.
Yeah, just to address Vino's point, Vino, most of these patients did have cardiac CT scans. That was part of the trial protocol to exclude left main disease. So we can't carry it away and say patients don't need angiography. They need some form of angiography, because if they have left main disease, then there is a prognostic value of revascularization. Because the issue here is that for 3-vessel disease, studies have shown time and time again that revascularization doesn't have prognostic benefit, especially if the LV function is normal. But I think the question looking at this central illustration is to ask ourselves, why do patients have coronary revascularization? By and large, the main presenting symptom for these patients was angina. They were getting chest pain. So they were not having surgery or PCI or the angiography to avoid death or myocardial infarction. Indeed, if you look at it, the myocardial infarction rate at 5 years was just over 10%. The death rate was just over 10%. So for the majority of patients, the benefit doesn't lie in either death or myocardial infarction. And the key endpoint here, which is not being considered, is quality of life. And the real question should be, what happened to the quality of life in the patients where angiography was delayed and those in which it wasn't delayed?
I agree with that, Ani, 100%.
Yeah, Steve, quickly.
Hey, Joe, I just want to reinforce what David said as some of the old guys on this panel here today, which I think is a great thing that we've done this, is, I was a Berry trial investigator, and the definition of myocardial infarction, perioperative myocardial infarction in the trial, we have to be very careful when we read these trials, because it can skew the answer one way or the other. It's very important.
I'm going to come back to that real quick, because we can't stay to this area. Next slide. So regarding another point, next slide. I found this to be very interesting when I looked at the conclusions in the New England Journal of Medicine. The trial findings were sensitive to the definition of myocardial infarction that was used. So there you go. And that will be a lead into the next slide, which is the XL trial.
Such a kumbaya thing, Joe. That's such a kumbaya thing to say. Come on. I mean, they got to have better. I mean, this is New England. What kind of sentence is that in New England Journal of Medicine, man? Seriously.
So the XL trial, I don't want to get into the XL trial, but it was a definitional issue as well. Real quickly, David, do you want to say a little bit about this definitional issue and how it applies to ischemia as well as XL? We've only got about 2 or 3 minutes before we got to go to the next section.
Well, it's so very briefly from the 1,000-foot view, if I would advise everyone to scrutinize whatever definition is used in a given trial and compare it to definitions in other trials. And what you'll find is that the definition fluctuates. And as Steve has pointed out in the Berry trial, that was an excellent example of the impact of the definition of MI as you try to compare the results of PCI and CABG in particular. And so in the XL trial, they chose a particular definition that some considered far more favorable to PCI than to CABG. So without getting into that discussion, if one assumes that to be the case, then right off the bat, you can see how the two groups are going to separate immediately, which they did. But if you modify the definition of procedural myocardial infarction using the data of the XL trial, the curves are virtually superimposable, with a perhaps advantage to CABG. And regardless of the definition, however, what doesn't come out in the XL trial is that if you evaluate the data using Bayesian analysis, there's a clear advantage survival-wise for CABG. And so anyway, I would sum it up by saying the definition is extremely important. It will influence the outcome of the data. If you're a really shrewd trialist, you can set things up in a trial at the front end to favor one group or another, pending the definition you use. And so we just simply need to be aware of that as we read the literature.
Along those lines, David, I think it's also important that we come back to also what Mark said earlier, which is don't forget the prior literature, right? I mean, a lot of people are looking at ischemia and, as Mark said, forgetting about Barry and forgetting about all our other trials that were very carefully done in sub-selected cohorts to look at individual patient groups with comorbidities. So,
But Pavan, it's important for surgeons who are on these trial executive committees to speak up and make sure that the definitions have a balance in that, because you're right, David, if you're not shrewd enough and you're just kind of listening to the calls but not really paying attention, this will skate right by it. And we have to make sure that our surgeons who are doing these trials are really spending some energy and some really hard work and making sure that it's balanced, not one way or the other.
Yeah, good point. Good point.
There's one thing that's important for us to remember.
So wrap it up, Mark, in 1 minute.
Yeah, double counting. Double counting is the issue here. The SKY definition that was used in Excel was used because it was predictive of death and poor outcomes and MACE. But those are already included in the primary composite outcome of the trial. And very few actually happen after the 30 days after the enzymatic release from CABG. So it really doesn't make any sense. It's a form of double counting. And you can't argue with 38% less odds of death in the CABG versus PCI group without even a Bayesian analysis. As you can see here, that confidence interval is statistically significant with a very small p-value, way less than 0.05. However, you cannot find it in the New England Journal paper.
All right. Well, this is very interesting. Okay. Next slide. So now we're going to turn our, and I just want to say about the ischemia and XL trials, I speak for the STS in a sense that one of our goals and duties for our membership of across the world is to make sure that we try to take these trials and make them as easy to understand as possible and to check the nuances, so to speak. Okay, so our second big trial here that we're going to be going over are the low-risk TAVR trials, and especially look at the new 2-year data of the P3 low-risk trial. So we'll start off by looking at the 1-year data from the P3 trial. This was in the New England Journal of Medicine. Next, and it showed basically, as you can see here, 454 patients. There are 500 patients in each arm, and what it showed is that 1 year TAVI was considerably better at the composite endpoint of death, stroke, and rehospitalization compared to surgery. And you can see most of that issue was in the very first 6 months. As you can see, the lines are fairly parallel after that, which we can get into later. Next slide. Now, also, just real quickly, this is the low-risk trial from Medtronic for the Evolute. Next. And basically what it showed was at 12 months and 24 months, there wasn't a whole lot of patients at 24 months, but the bottom line was this was statistically not significant between TAVR and surgery for low-risk cases in this New England Journal paper. Next, which brings us now to the 2-year clinical outcomes of the PARTNER 3 low-risk randomized trial. Next. Now this paper was presented at the ACC about a year ago and was published just recently in JACC. Next. So what it showed at 2 years was that gradients were stable and actually better for SAVR a little bit, even though it was not statistically significant, which is the first time actually that's ever been shown.
It was significant.
It was significant. Oh yeah, P is 0.001. I'm sorry, you're right.
Not
Next.
clinically.
Next slide.
Yeah, not clinically significant.
Yeah.
basically, there was no paravalvular leaks in the SAVR group, as is usual, and about a mild paravalvular leak of 26% in the at 2 years in the TAVR group. Next. But the most important slide is this slide, which again showed a p-value of 0.02 favoring TAVR. And then next slide, next push. You can see that this completely narrowed up with a p-value of 0.47 at the 2-year mark. And if you look at a landmark analysis, it would be pretty amazing if you started it at 3 months. Next. So the question for the panel and for everybody on the line is low-risk TAVR trials, especially the 2-year P3. What do these results mean for the global STS membership? Next slide. So this is the next. This is the central illustration. So I'd like to start off with Katherine Harrington. Katherine, what are your thoughts about the P3 2-year data set?
Yes, thank you. And thank you, Joe and Pavan, for having me. So I think this shows that, TAVR is not yet the panacea and ready for prime time. We as surgeons should still strongly advocate for surgery until, especially in our younger patients, until this has a proven durability. As you can see, the curves are starting to converge. And if you even look at the P2 5-year data, they're starting to converge even more. I think TAVR is certainly a great technology, especially for our older patients, but I think we should still have a fair amount of caution in using it in patients in their 60s and below. And similar to what we looked at the Ischemia trial, the definitions of the trial and the trial strategy certainly matters. I think adding rehospitalization to the P3 data certainly favors TAVR. As we all know, surgical patients have a couple bounce backs that are perhaps not clinically significant for thoracentesis or fluid overload that might not matter several months or years down the road.
Yeah, that's interesting. I actually think that the rehospitalization endpoint will favor TAVR in the short term. As you can see here, it's obvious. However, it might actually be an issue for the TAVR cohort later on.
Joe, maybe I can be the devil's advocate to Catherine's great point, and I want to hear Vino on this. Like, TAVR is still ahead of SAVR at 2 years, right? And although that's mostly driven by hospitalizations, I guess what you're saying, Katherine, is could this be like the CABG versus PCI trials, that the more that one follows up, the more surgery gets ahead, right? But I think it's a bit different here. CABG versus PCI is biologically extremely different. Here is if these prostheses hold up, they should be okay in the long term. I mean, if you can avoid upfront morbidities and strokes and et cetera, and the valves, the prostheses are good, then I don't know if it's going to catch up.
I'm not necessarily. Sorry.
Yes, sir.
So, yeah. Well, first let's let Katherine answer real quick for a few seconds. Go ahead, Katherine.
I would say I don't think that once the valve is in, they're essentially equivalent. You know, there's the issue of halt with the TAVR valves. There might be some more increased risk of thrombosis with these leaflets. Just because the leaflets are made of the same material, I think not removing the native valve, the calcium around it, it does mess with the flow patterns. I think you still have possibly might have a higher risk of stroke and thrombosis, leaflet thrombosis, because the flow patterns around the leaflets are different, even though they're made of the same materials. So certainly the procedural outcomes are equivalent. And if you're 80 and you want a quick recovery, I think it's an excellent technology. But if you're looking for long-term durability, I don't think we have that answer yet. It certainly might be the same, but I have some concerns about the TAVR durability with the thrombosis and seems like the strokes are slowly catching up as well. Whether that's left over from the native valve or the leaflet thrombosis, we'll have to see.
So here, Katherine, Joe, can I have a comment?
Yeah, Vino, comment, and then I'd also like you to comment, Vino, specifically since you're on the committee, the executive committee of the partner trials, and you're an author of this paper. What is also driving the stepwise ladder between years 1 and 2 in the TAVR group?
Yeah, Joe. I think first of all, this makes it a lot harder, quite honestly. And to Mark's point a little bit, if TAVR is non-inferior to surgery, it's going to win. Okay, so just because it's a less invasive technique, I think what's going to be really important, I'm not sure I get too much information from year 1 to year 2. I think it's going to be for low risk patients. I think it's going to be year 3, year 4, and year 5. If the graphs, if you see the blue line after 2 years continue to go up and the yellow stand still, then I think Katherine has some points. If this is the end of it between year 1 and year 2, and you've seen that rise in death and disabling stroke and it plateaus there, like surgery, it plateaued a little bit earlier, then I think that TAVR is going to win. I have to be honest with you, because if, again, non-inferior goes to the technology that doesn't allow you to open your chest up.
Absolutely.
So I think that year 3 and 4 are going to be really the critical things. I don't think any side has won at this point. I think it's right now a crapshoot as far as what's going on, as far as that goes. So that's that part of it. And what's driving most of the stuff from year 1 to year 2 is you are seeing some increasing thrombus stuff from year 1 to year 2. You are seeing a little bit more strokes in the TAVR population in year 1 to year 2. And that's what's causing a lot of that. It's not necessarily rehospitalizations and things like that. The difference is that when you see some of this SVD, structural valve deterioration, the therapy for that is another valve and valve, and that has a very low morbidity and mortality. The morbidity for having a surgical valve breakdown is mainly through endocarditis, and that's a high mortality because you have to reoperate on those patients. So I think the jury's out. I don't think anybody has won, but it now at least gives us a little pause between year 1 and year 2, Joe.
You know, I will say this. I agree. I agree with you completely, Vino. But here's my one concern, right? Is in the low risk patient population that we're at 2 years now on the TAVR data, and we're seeing a concerning trend. I agree. We don't know where it's going to go. But those of us, you know, are in clinic, and most of hopefully people on the webinar. And if you see young patients, and I don't necessarily define patients in their 40s, but also including patients in their 60s and potentially early 70s.
Yeah, this is 73. The mean age, Joe didn't show for low risk, 73 is the mean age. Just remember that.
Right. So, and then we've got data long-term on surgical aortic valve replacement out to 20 years. So,
Pavan, listen, that data is not adjudicated. That data is not randomized. Their echoes are not done in a good way. You have to throw some of that stuff away.
All right. I agree with that.
Vino, I think that you did the most important point I got from what you just said is the dangers, given that this is a journal club, of using the wrong endpoints in a clinical study, because that's what Dr. Bavaria showed clearly.
Yeah.
The 1 year study was published, and based on that study, the CMS approval for transcatheter valve replacement changed. The guidelines changed, which we're going to go through in the next discussion.
Yep.
So class 1 recommendations were made based on that 12-month study. And the 24-month study, as Dr. Bavaria showed very clearly, has shown a totally different result from the 12-month study. And you have summarized it well, Vino, saying that we don't know the answer.
Right.
And the question is, if we don't know the answer, how come practice changed based on an inadequate study with the wrong outcomes?
Because even if you look at the low-risk Medtronic trial, it was non-inferior. So at non-inferior, if it was inferior, I think that
but Vino, as you said, the problem is the wrong time point. It's not.
Yeah.
The problem is where, as you said, we won't know yet. We don't know. And we will know in about 3, 4, 5 years' time.
Yeah, I think we'll know in 2 years, Ani.
Or in 2 years. So why would the guidelines change? And why would we change our practice based on an inadequate study that we all know is measuring the wrong outcome?
Okay, guys. So just hold on for a minute. So we actually got a few questions from the world here, and I'd like to throw some of these questions at you. So if one of them is what we're talking about a little bit. For a low-risk patient, shouldn't we be waiting for 10-year data or certainly longer than 1 or 2 year data? I totally agree. I couldn't believe the FDA actually gave this as a 1 year data point. I thought they would go 2 years like they did for the intermediate trials. However, so let's roll that question in there with the let's see here. How long are the partner studies planning on following patients, Dr. Tehrani?
10 years.
The answer to that question is 10 years. So can you answer quickly about the question about should we be making decisions on, 2-year data for this, for low risk patients?
So I think that's it's very difficult. Like Pavan said, we see all these patients there. Everybody wants a TAVR, but that's not the right answer every time. The heavy bicuspids. I think that this is going to be a local heart team, what their outcomes are for surgery. And Joe, just to let you know, if you do 1 to 25 AVRs a year, you have a 3-fold higher mortality. Okay, for surgeons, you have a 3-fold higher mortality than what the STS predicts. So every surgeon out there is not doing the same level of work as different surgeons. So I think that there's some balance that we have to look at this. But I would say that it's going to have to be with your heart team for your capabilities with surgery, your capabilities with TAVR, your outcomes in both, and also where the patient fits in and what they want as far as that whole aspect. But you have to be honest with them, and you have to tell them this data. You can't just say, you got to give them, I tell them 2-year data. I don't tell them 1-year data, Joe. I tell them 2-year data.
1-year data is history.
1 year, yeah.
So David Fullerton, you're the wise one. What do you think about this?
The wisest.
Well, I don't know about that, but I'd like to emphasize the point Ani made. And that is if you look, this is a composite outcome that's driven by readmissions, right? But the implications drawn or the conclusions drawn from the study are focused on the efficacy of the therapy in terms of treating aortic stenosis. I would personally argue that it's inappropriate to include readmissions as an important aspect of a composite outcome. And in fact, if you remove that, suddenly these lines are superimposable for the first year. And for years 1 to 2, the blue line is now higher than the yellow line. So it gets back to the point that we emphasized earlier in making sure that when these trials get set up, that the definitions that go into these composite outcomes are not going to immediately bias the results in one direction or another, which personally I think this is done.
So here, I'd like to address this to Katherine Harrington, because this is a question from the audience again, I think from Europe. It says, interestingly, P3 2-year data shows less gradings for AVR. Will this matter in a V&V or valve-in-valve strategy later on?
I do think that, one of the good things about TAVR is that it has pushed us to kind of surgically up our game. So we've focused a lot more on root enlargements and getting a better prosthesis in. I also don't think valve-in-valve is really ready for prime time. That's only still approved for high risk. It is not yet approved for intermediate or low risk. But now that we've been doing TAVRs, I think most of us surgeons are a lot more focused on the index operation, trying to set them up for a second valve-in-valve if we possibly can.
Katherine, when you say valve-in-valve, you mean TAVR and TAVR or TAVR and SAVR? Because TAVR is SAVR is
No.
good if you get enough size.
I meant TAVR and SAVR because he was talking about the surgical gradients for the surgical arm. So setting them up for a TAVR and SAVR, which I really don't think is ready for prime time yet. But we're still, there's no reason not to at least try to maximize your platform for that if that's where it's going to be in 10 years.
Okay. So one more question from the attendees. With the younger patients and low risk patients, again, this is about a valve-in-valve issue. But I suppose what they're trying to say is, in younger patients, do you think the valve-in-valve operation would be better or worse in a TAVR versus a SAVR? Vino or Dave?
So maybe I don't understand this exactly. You're talking about, is it better to have a TAVR inside a SAVR or a TAVR inside another TAVR?
Correct. That's the
So
question.
it depends on the size. This is where size matters. Joe, you talk about that. Maybe that doesn't matter, but it does matter. Size matters here. If you a surgeon puts in a 21 valve, that TAVR valve in the SAVR ain't going to do very good. Okay. If you put a 23 Sapien 3 in or a smaller, core valve, then that TAVR and TAVR is not going to do great. So I think it depends on the size of what it is. Surgeons really need to put in 23 valves, root enlarge as much as you can. And I think that's really what's going to matter. I don't think we have any data. We don't have any data on what's better down the road but we do know that it can't be in a small valve at the initial surgery. That's the killer.
Yeah.
Okay.
Don't forget our new technology that's out there with surgical valves that have expandable cages either. You know, there's other ways to think about this hybrid approach. And I'd also caution people in terms of getting too young in terms of the hybrid approach. And don't forget about the mechanical valve.
Yes.
It's turning into a bigger and bigger battle talking to patients about long-term survival and the benefits of mechanical valves. But I think as surgeons, we owe it to our patients to have that conversation.
Joe, can I just one comment that I just wanted to tell David, because you asked about this. If you look at death by itself, David, surgery is 3.2. Just surgery is 3.2, and TAVR is 2.4.
Right.
So that's just death. Take out hospitalization. Take out stroke.
Yeah.
There's 0.47 is the actual p-value for that. So at that point, I would say at 2 years, death only is still non-inferior for both. So that's why I think it makes a difference. So it's not just hospitalization. The graphs look superimposable with a little bit of change of numbers for even death at this point. Okay.
Well, we'll have to see how things go. One of the attendees talks about cardiac surgeons, cardiologists, and the guidelines regarding this. And I think this will be a nice segue into the guidelines discussion. So let's go to the next slide, into the third session, or the third segment of this. So let's talk about, with this august panel I have here, the new guidelines that came out, which are quite interesting, and there's a lot of new valve situations with the guidelines. Next slide. So let's take a look at the aortic and BAV guidelines. I think we can only spend about 3 or 4 minutes on each one of these, so we'll try to be tight. Next slide. So this is the guidelines about intervention. So I think it's about timing of intervention. So the first thing I wanted to look at the areas is severe low flow, low gradient, severe AS. That's a new guideline, which is a 1. Looking at low flow, low gradient, severe AS with AVR recommendation. And then if you look at the 2A indications, there's indications about looking at in asymptomatic patients, and these are actually a lot of asymptomatic situations with severe, very severe AS, as looking at asymptomatic at a 5 meter per second. That's new. So using that velocity to utilize a 2A indication for AVR. Also the use of BMP, which I thought was pretty interesting, at only 3 times the level. I don't do that, and I think I might start doing that, as well as looking at a kind of a consistent increase in velocity of only 0.3 meters per second per year, which I think in my clinic anyway happens quite a bit. So I suppose to start off with, maybe Ani can talk about this first, about the intervention. Anything new, any comments regarding the timing of intervention in the AS guidelines? Ani?
No comments so far now.
Okay. Anybody else?
Yeah, I think the BNP, I think that biomarkers, Joe, are going to become more important. And, in one of the trials, the early TAVR study, which is on asymptomatic patients, not in surgery, but in asymptomatic patients for medical therapy versus TAVR, every patient is getting blood drawn. And I think that we're going to start learning a lot more about asymptomatic aortic stenosis and how to gauge when to do something with these patients based on these biochemical markers. I think this will become a bigger issue, or a bigger pathway for us down the road.
I agree.
And hey, Joe, if I could just comment, I think in heart
Steve,
failure and mitral regurgitation, I think biomarkers, I don't know if it's going to be BNP, but I think we're going to see a lot of influence on biomarkers moving the patients to therapy early.
Yeah.
I think that's an important change we'll see relatively soon.
Maybe they'll come up with an ASNP, aortic stenosis, peptide or something like that.
So if you guys remember,
the reality though, Steve, is most patients with elevated biomarkers will not be asymptomatic. So I suspect you might get to that, but if you exercise these patients or do something more functional, you'll find that if your BMP is 3 times normal, that you're not asymptomatic.
So
you know
Annie,
what,
Ani,
though? I don't know if we have enough data on that yet.
No, that's what Ani. I think that's what the early TAVR study is specifically looking at. We don't have data on that, and that's what they're looking at. Exactly what you're saying that we don't have data on.
Sorry, we
Well,
don't
that's
have
also why-
we don't have data and it's in the guidelines.
Well,
No,
You see, that's probably going to be the theme for the next 15
Yeah.
minutes is
no,
no data-free guidelines.
consensus. Maybe it's a consensus, honey.
Tanya, along the same lines, I think point 7 here is important. And it's also interesting that now in the era of AS, traditional teachings, chest pain, syncope, and and dyspnea on exertion. The moment you have those symptoms, we start intervening. I think it's very interesting that we're starting to get into the asymptomatic world with AS more and more. Though I do, along the same lines of the biomarkers, wonder if you've got a patient with an aortic velocity rate of 5 meters per second, I'm not sure they're asymptomatic.
No, I agree with that.
I think the main thing here is
that
that
the key here. That's really the key, like the asymptomatic patients that's derived from the Kang trial in South Korea. And I think the other important point here is that it's really surgical AVR, right? Because that does not apply to TAVI. We cannot overgeneralize this to TAVI because in TAVR trials, all patients were symptomatic with a gradient of 40. So this is ready for surgical AVR in low-risk patients.
Yeah, I think the big picture for the audience regarding the timing of intervention for AS are the nuances in asymptomatic patients. The 4 arrows I have there are all brand new indications, and they're all kind of related to these nuances about asymptomatic AS and when to operate. So that's kind of a cool thing, I think.
Yeah.
Okay, let's go to the next thing. So this is looking at mechanical versus bioprosthetic valves. And if you can see my red box, the left side's pretty much the same as it's always been. The red box though is basically segmenting these out into age. So 50 years or less, mechanical. 50 to 65, either way, talk to the patient. Greater than 65, tissue valves. Any comments from the audience? Katherine, do you have anything you want to say about or tell the audience about this particular recommendation? Because this is a little bit different than it was before. It was segmented only into greater than 60 and less than 60 in the previous guidelines.
Yeah, I like these new guidelines. This is about what I do clinically. I say under 50, I strongly push mechanical, over 60, 65, and then in the middle do a shared decision making. I do think, if there's an ongoing trial for the Onyx valve right now with Eliquis, if that is positive, it's going to change the ball game as well. There was that New England Journal of Medicine paper from Stanford that showed there was a survival benefit 55 and under for mechanical valves. So like other people have said, I think we shouldn't forget about mechanical valves. They can provide a better lifetime mortality risk compared to TAVR or SAVR. And then down there at the bottom, there was a recent Ross paper in New England Journal of Medicine that showed excellent outcomes at 15 years, 92% lack of reintervention for the autograft and 97% for the homograft. So our center has stayed a strong Ross proponent, and we do a fair amount. So for people under 50 who refuse a mechanical, we also push them strongly to the Ross procedure. I think if you're going to open someone's chest now, you really got to make it worth their bang for their buck. If we think a surgical bioprosthetic and a TAVR bioprosthetic are going to be equivalent, if their chest is going to get open, we got to give them a better option.
Yeah, as an aortic root surgeon, I would agree with that, that the Ross procedure is making a comeback and is a very nice operation in certain patient subsets. We're doing Rosses, we're rediscovering Rosses as well. As you can see, I've got enough gray hairs where I was doing a whole bunch of them in the 90s and early 2000s, and I'm doing them again. So this is actually the first time that the Ross procedure has been in the guidelines for quite a while. So that's a new thing. Any other comments from the group about bioprosthetic versus mechanical?
Yeah, Joe, this is Mark. I think we have to be very, very careful here. This is largely based on expert opinion, on a number of observational studies, a number of registries with selective reporting. This huge confounding indication in allocating whether someone gets a mechanical valve versus a bioprosthetic valve, including the huge specter of endocarditis. I think to me, it's still about patient preference. I was trying to say earlier during the animated discussion, I've changed actually my consent process. Patients who don't want to be anticoagulated and don't want reoperation, all these young patients that we all have, I've actually changed my consent. If I can get a 23 or 25 or larger, they're going to get a bioprosthesis. But if I cannot get that in easily, including with root enlargement, then they get a mechanical valve. And that's kind of how I consent my 50-year-olds and my 40-year-olds now who need this. And I still stay away from the Ross procedure because there's a lot of
Mark, I'm right
at a Ross who are not part of the registry reports, right?
Yeah, Mark, I'm right on that with that also. I do have a deal with the patients that if I can't get a 23 or 25, I'll put a mechanical valve in them. So I do have kind of you might wake up with one or the other valves, and patients are quite okay with that, honestly.
That's an important part about the heart team decision. We do that where even our younger patients who are probably going to get a surgical valve go through our valve clinic and get the TAVR CT. So we know exactly the size of the annulus ahead of time. And I think that really helps with decision making for that. Certainly there are times where the annulus size will push us towards a mechanical compared to
Katherine, my surgical, all my patients get a TAVR CT also.
Mine too.
So
it's very helpful.
Yeah, that's pretty much standard of care. Here's a question from the audience, which I thought was it's a little snarky maybe, but are these biomarkers intended to get patients to TAVR earlier or to SAVR earlier or both?
So the trials, the early TAVR trial does not include surgery. It is a patient comes in, they get a stress test. If they fail the stress test, then they go to TAVR. They're not symptomatic. They're symptomatic, not asymptomatic. And if they pass the stress test and they get randomized to medical follow-up, continued medical follow-up versus TAVR, surgery is not a part of that. The national PIs are 2 cardiologists and no surgery.
Well, I think the answer to the question is, is probably both. That these nuances that were presented in the previous slide will probably get patients in, asymptomatic patients in, to both sets of treatments.
And they're not in the trials.
Let's go to the next slide. So this is SAVR versus TAVR, and I thought this was interesting because the bottom line with this is that we've always been thinking about. This is for the audience. So we've always been thinking about high risk, intermediate risk, and low risk. Well, it seems to me that the guidelines committee kind of chucked that whole concept and basically went with age. And as you can see in the box, this was interesting. Basically, they said SAVR is recommended, no ifs, ands, or buts about it if you're less than 65, or if you have a life expectancy over 20 years, which is interesting because if you look at the tables, life insurance tables, as well as the data from the U.S. Census Bureau, if you hit the age of 70, you have a 20-year life expectancy in the United States. So the second one is if you're 65 to 80 or 65 to 79, you can go either way, and this is basically I think is an admission that the P2 data, P2A data, and the P3 data are probably not ready for prime time yet. We can talk about that. And then if you're over 80, everybody gets a TAVR. So I suppose we should start with that concept first. Anybody, David, do you have any comments on this?
I have to admit I was a little surprised by him, Joe, because I think it, as Vino has already emphasized, and we all know, everybody wants a TAVR. And so to come out with these, recommendations, which really strongly favor SAVR, even in patients that are already getting TAVR, I was a little surprised by it. So.
Yeah, me too.
Katherine Otto is the chairwoman, and she's a cardiologist, a very good one, I might add. So,
she's better now.
Steve, you have any comments, or Pavan, Ani, anybody?
Well, I have to say, just this discussion, as you know, I'm not a TAVR guy, but let me be a bad person and say patients don't want heart surgery. They want catheter-based therapies. And I think we have to take that into account with all the things that we think about for these patients. Patients are not going to let us beat them over the head and say, this is what the data says. They want catheter-based therapy. We just have to be aware of that.
Well, I do have an issue with the first 3 recommendations that are all class 1. They give a level of evidence of A, but there's no randomized trial that randomized patients less than 65 to 80, or more than 80. the references listed there from 123 to 125 are meta-analyses of the trials we've been talking about. So how the guideline writers say there's level of evidence A, that someone less than 65 gets surgery, someone 65 to 80 we're indifferent, and greater than 80 gets TAVR, there's no basis for that. It's consensus, but they put A, and these are guideline documents that everyone around the world is supposed to read and believe. I'm actually shocked that we have stuff like this in writing.
I agree with you, Ani. I think that they jumped the gun a little bit even on point 2 here. I think you wait for the low risk data to come out before you make recommendations.
I don't know. I actually agree with David. I thought these guidelines, frankly, were more pro SAVR than I thought they would be. I thought that the ACC presentation, because the journal article wasn't out yet on P3, on P3, the ACC presentation, as well as the P2, Vino presented the P2 5-year data. I think they kind of hedged, they kind of came back a little bit and are basically waiting for the 3, 4, 5-year data from the low risk trials.
Yeah. I'm surprised. This is more pro surgery than I thought it was going to be coming out of the ACC and HA. I have to be honest with you, saying anybody under the age of 65. First of all, I'm not sure that there's good, 1A evidence for this, just FYI.
Yeah. The point, Vino, is there's no evidence on which to make these recommendations. So it's not whether it's pro-surgery or pro-TAVR. The question is it evidence-based? Level of evidence it is.
Okay, stop. Hold on. Katherine, go ahead and say your piece.
Oh, I was going to agree with everyone. I think that I don't disagree with these recommendations, like anecdotally. I think they are a little more pro-surgery than I expected, but I don't think the evidence supports them to this level.
So, wait a second, guys.
There's not.
We've done more randomized trials in the last 10 years in aortic stenosis.
They are better than others.
Ani, than we've ever done with mitral regurgitation for the history of medicine. We haven't done. Somewhere you can't say we're going to have 15-year data.
I'll take the moderator's prerogative here. I agree with Vino that it's pretty well studied, and you're never going to get anything better studied. I think that these guidelines are pretty good. I think these guidelines are following the data, and the data is equivocal for some of these subject groups here. So
there's one point that we need to make that should be important here in point 6. This is, again, for transfemoral AVR. When we start to talk about alternative access, when we're starting to talk about axillary and transaortic.
Wait a minute, Pavan. So let's just run this to Pavan right now, because I know we have Katherine and David and Vino on the line, and it's a very important. I found that these guidelines were completely dissing alternate access TAVR. Okay, every single thing in here is transfemoral TAVR only. So I almost wonder, does alternate access TAVR even have a place anymore? If you need an alternate access TAVR, should you just get an AVR today? Because I don't see anything in here that's supportive of alternate access TAVR. Okay, David.
So the reason for that are the outcomes are worse with alternative access. But having said that, in my own experience in our program, the people we're doing alternative access on are really not good open candidates. So I personally, I think it still has an important role, whether it's transcarotid or axillary. We actually even did a transapical the other day. But I think I noticed the same thing, Joe, that there's consistent reference to transfemoral only. But I think there's clearly a role for alternative access.
Okay, I'm going to have to take the.
Joe, I disagree with you a little bit on that, just to let you know.
Okay, that's all right. I expect it, and I have broad shoulders. So but we have to move on to the next one, or we're not going to get it. Next slide. Okay, so these are the chronic AR. So let's just spend a few minutes on this and move on. This is for the new guidelines for chronic aortic insufficiency, and I think that there's a couple of issues, a couple of new things. The first one is that the left ventricular ejection fraction for AI was increased, so to speak, for surgery from 50 to 55. Should be noted that the Europeans are using 60. So that's actually going to bring more patients into the AI fold. And in asymptomatic patients, as you can see with the bullet with the 2A indication, the LVEF is at 55 instead of 60, but also the LVESD, the systolic diameter, came down from 55 to 50, and also included a indexing with an LVESD of greater than 25 millimeters per meter squared. I tend to use sometimes 22 millimeters per meter squared. But down below in the 2B, it still has 65 millimeters as an end diastolic diameter. Any comments from any of you on these guidelines? Katherine, anything?
I feel like this has changed 2 or 3 times throughout my training just to confuse me for board exams, but it went up and then it went down and then it went up. Dr. Fullerton actually did my oral board, so thank you for passing me. But you know, I'm interested. There's no biomarkers on this slide too. I feel like that would maybe be even more useful for AI compared to AS. So it's.
I think just as an AI expert, I find that the focus on end systolic diameter is actually really, really good, and the defocus on end diastolic diameter is probably a good thing too. So I think they're moving in the right direction, although that unfortunately in the AI aortic valve insufficiency world, data's sparse. Steve, you had your hand up?
No, I disagree that I think that the biomarkers are going to be actually more important in regurgitant lesions than they are in stenotic lesions.
That's an interesting point. I think that's an important point. Okay, Mark.
If you got AI and your LV is 48 millimeters and systolic, you got a problem, and it should be addressed, right? Unless you're dying from something else. I don't even care. I think 50 is even still conservative.
I do too. It went from 55 to 50, and I think the next line is going to be 45. And the LVSD is going to be 22 millimeters per meter squared.
So listen, I'm tired of seeing AI patients who have EFs of 10 to 15% in the clinic. I'm tired of it because I can't do a damn thing for them. Whatever we're doing, we're waiting too long to manage these patients. That's why.
Put them on a treadmill. I guarantee they're symptomatic.
In circulation a few years ago. It's not 6 months. It's not 9 months. It takes 5 years for the LV to recover.
Okay. Yes, I agree. It's bad. This is where the guidelines, not just this set, but all the sets have been deficient. But there's just no data, so it's incumbent upon us academic surgeons to get more to produce more data. Okay, next slide. This is quickly BAV. I thought it was interesting. They're both 2B indications. That aortic valve repair has a BAV 2B indication, and that also TAVI may be used in bicuspid valves. Vino, do you have any comments on this?
I think that you and the guys at Penn and Pavan have really driven this. I think that's the repair for bicuspids is really driven by your institution. I think that's great. And I think that's something that should be more part of the recommendations. I really am happy about that. There's not great data on bicuspid and TAVR and TAVR right now. And I'm a little surprised that's in there, but you see the level of evidence is not very good.
It's a 2B indication, so it
should be.
I would say I'd be the devil's advocate. I would say tread carefully. Make sure your outcomes are good. This is 2B. Let's not start doing but for everybody with bicuspid leaking valves. Right?
That's what I'm saying. Hopefully, people don't walk away and say, "Oh, it's on the guidelines." That's a mistake. They don't,
carefully.
But just for completeness, though, this is the same level of recommendation for the Ross operation.
Yeah.
So those are the guidelines we have. The Ross has a 2B, and a TAVI for a bicuspid aortic valve is also a 2B. Those are the guidelines.
Yeah. Well, that's why we need to do better. We need to do some randomized trials with Ross. We need to get in there and do something from a surgery point of view.
I think it's important to for the audience across the world to understand that these are 2B indications, but they are new. These are new indications that have never been in the guidelines before. So that's why I highlight them, and that's why they're important.
Yeah, that's great.
But it's important to understand, just as Azani and Vino say, 2B indications are pretty soft, right, Steve?
So, Joe, I've always thought of 2B indications as very Shakespearean. To be or not to be, we have no idea.
I love it.
Only Steve would know that.
Hey, Joe, it looks like we're at the end of our hour.
No, yeah, we're allowed to go a little bit more. Next slide.
Okay.
Not done yet.
Okay, let's go through the mitral guidelines. I've been told by the leadership of the STS I can go another 10 minutes or so. So mitral guidelines, next one.
On the paper plus the mitral.
Okay, so the mitral guidelines. Steve, anything new on the mitral guidelines? This is for chronic primary MR.
Yeah, no, there's not really new. I mean, it's still in our minds, it's 60, 50, 40 AFib. People were looking for a left atrial dimension or an index left atrial dimension guideline. I'd like to see that. But, you know, again, in an effort to move people to asymptomatic repair of mitrals.
I think there's two things, though, that we should think about. One is, totally agree with you, Steve. Globally speaking, not a lot that's new, but one is, I was interested by this concept of a comprehensive valve center that's more and more emphasized in the mitral guideline. And the second is MitraClip or edge-to-edge repair. And again, they say it's for high risk, and I think it's important that we think of it as high or prohibitive risk until we have more data. And I've got to tell you that in our local community, I'm seeing more and more intermediate and occasionally a low-risk patient gets a MitraClip and then I end up reoperating on them. So I think
I've seen that too. Well, I've reoperated on a fair number of MitraClips gone sideways. These have been in the indications. This is not new in the indications, but yes, the concept of a valve center and a clip or tier, as we call it now, edge to edge, you know, is an important part of our armamentarium in our toolbox from chronic primary mitral.
It's just they're not as radical of changes as they were in the aortic space, I think, Steve.
I agree.
Well, actually, Steve, if you take a look at number 5, because I was a bit shocked by that one. So number 5 says if you're asymptomatic with a normal ventricle, so your ventricle, your EF is more than 60, your LV ESD is less than 40. Normal ventricle, asymptomatic, but there's been some increase in size, but you still haven't met that size threshold. It says you can have surgery regardless of whether it's a repair or replacement.
Again, 2B though, right?
That's yeah, but
no, it says durable repair. I think that's a repair indication.
It says irrespective of the probability of a durable repair, because in the previous guidelines, the only context for asymptomatic surgery was either a dilated ventricle, dysfunctional ventricle, or if you can guarantee a repair by 95%. But now the new guidelines are introducing the concept of valve replacement in an asymptomatic patient without ventricular triggers. And that's something very new, which is alien to most mitral surgeons.
The 2A talks about the 95%.
Yeah, this is a 2B indication again, and with evidence of level C, meaning C, they were drinking a lot of cognac and just came up with this.
So that is true. It's a 2B indication, but it is new and it's interesting in a sense. That's why I put the red arrow on it. It's interesting to me as an aortic valve surgeon who does a lot of AI, is a left ventricular end-systolic diameter of greater than 40 millimeters here. Why is it here and not on the aortic valve side? I don't understand.
Katherine Otto doesn't like aortic regurgitation as much as she likes mitrals.
All right. Let's go to the next slide. So Ani and the mitral guys, can you talk to me about this? Is secondary MR guidelines. I found this a little bit, this is basically looking at ischemic MR and also the concept of, mitral France versus coapt. Obviously this was a big difference in the guidelines on secondary MR. It was informed by the coapt and mitral FR trials, as well as the NIH trial regarding replacement versus repair. Can you guys comment on these for our audience out there in the world?
Well, I'll take the. Go ahead.
I think the number here is 70, right? You got to remember that number. The LV has to be less than 70 millimeters. The PA systolic has to be less than 70. This is the difference between coapt and mitral FR. They were completely opposite. And
ideally even less than 65 if you look at coapt, right? I mean, I think to indicate, again, talking about lack of a basilar aneurysm, a limited dilatation of the left ventricle, 70 millimeters, and then lack of tenting of that anterior leaflet of the mitral valve as well. So again, all key factors for durability of repair. And if you want to look up the reference, I would say look up the Annals paper that looked at the subgroup of the severe MR trial from CTS net that did not have recurrent MR. And if you look at that group, it defines the anatomy perfectly. That's the same group that did well and was the group that was studied in coact versus mitral FR.
Okay,
If
listen,
you remember that's based on 60 patients.
True.
So,
Steve.
you know, we hold those opinions most fiercely, those opinions associated with no data.
Yeah, that's a good point, Steve, but I just found it very interesting that it matched the coact patient population, right?
Agreed.
And we've
I
also
don't disagree.
it fails when the ventricles are giants. Mitral valve repair fails. Open and
Agreed.
and
Agreed.
Yep.
It
Agreed.
doesn't work. And I would even add aortic valve repair fails too, right? But that's a different topic.
Okay, I'd like to take the prerogative here. I want to give you guys a question, which I thought was pretty interesting, especially to Ani, if he's still on. There he is, which was to all of us, actually, including our Shakespearean. If we are going to poo-poo anything less than class 1 indications, why have them?
Oh, no, we don't poo-poo them at all. We just put them in context. I think a class one indication doesn't change with time. It would be very unusual. Class 1 indications are things that we are very certain about within limits. A class 2A indication would be something that is probably correct. Then 2B is a bit more vague, but no, they're all important. They all have their place. So we're not disregarding them, but we're just saying that if you're saying something is class 1, you really have to have strong reasons to do that, because we can't have the next iteration of guidelines that says something totally different within 2-3 years.
But I also, you see things moving, right? You see things go from 2B to 2A to 1. You see things go from 1 to 2A to 2B. So I think it's important to keep all of them in there to give ideas, because people are discussing all of these things that we're talking about.
And I think the 2B indications are important, because there are a lot of surgeons that practice in a very subspecialized, expert-based practice. And for them, the recommendations for them will be different from everyone else. So.
Okay, a couple questions.
I really like the idea that this has become an organic document and that it changes fairly frequently and it changes in response to new data. You know, the guidelines used to be written every 10 to 15 years and they weren't very helpful. I really like that the changes have. And yes, it may confuse some people because guidelines change a little bit, but I think it's important that this has become an organic guideline for us.
So listen, we have 2 minutes left, and I want to ask a couple of one key question, especially, which is in secondary MR, the concept of mitral valve replacement with portal sparing versus repair. These questions are coming up. Steve, you want to comment, and Annie after that, and Pavan?
So, you know, obviously the answer is clear as mud on what to do for these patients, but I think we have learned some things from a lot of studies in that if you're going to do surgery on these patients, there are some indications where you absolutely should not repair, you know, reverse angulation of the posterior leaflet, gigantic ventricles and so on like that. And if you're going to repair, use a small, rigid ring. And that's about the most I can say right now. Annie?
I think Vino hit on it earlier when he said we as surgeons have not done the studies and have not provided data. So we've lost this game. You can see 2A is just transcatheter. The other 2A on the bottom is someone having bypass surgery, which really isn't important. But apart from that, the rest of surgery is 2B or worse. And it will never change because we have never demonstrated that surgery in functional MR is beneficial to the patient. And it will never happen. So unfortunately, it's going to be catheter going forward for secondary MR. I don't see how that can change because it will be very hard for us as surgeons to provide the evidence to show.
Sonny, I think you're right. Today I did 2 10-dyne valves for FMR, right? I mean, and those patients probably back in the day, they would have been redo surgeries, but I would have probably done them open. Yeah. And now they go into a different pathway.
You know, I think we lost the boat in one key area, and that was, as surgeons, we were so focused on the annular level and the valvular level, we forgot about the subannular repair techniques, and that's probably what would have been important for repairing.
I think, Pavan, we forgot that we're comparing ourselves to medical therapy. So we just assumed, like Dr. Bolling told us for years, that it cures everything. We even thought it could cure cancer. So we just kept repairing all these functional valves. I mean, Dr. Bolling used to say, find it, fix it, ring it, and all that. That's all we did. we never did any studies that compared it to medical
Steve, it's your
therapy.
fault. Ani just said it's your
Okay.
fault. He just
Yes,
said
it
that
is.
on live webinar. Shit.
All right, guys. Well, listen, we can keep on going on and on and on. I have a lot of questions about the fact that the guidelines did not address the maze procedure in the mitral space, especially since it has 80% effectiveness and there's no real added risk. So we'll have to shelve that to the next time, Pavan, when your
I would
workforce.
add on this, Joe. Stay tuned for the ACC and the New England Journal of Medicine.
Okay, great.
Going to be
Joe, this
presented,
is what a great idea.
Answers there around left atrial appendage occlusion.
Mark, we'll have you back for that next conversation.
All right, and last, this is where Bolling. I want you to answer this really quickly. This is from Europe. I believe that there is a contraindication for class 3 for MVR in case of repairable mitral valve. I think that's only for degenerative. It's not for secondary, correct?
Yeah, that's correct. Correct.
Okay, so that's the answer for everybody there. Steve, that's from Steve Bolling. Ani, you agree with that?
Yes, I do. Yeah.
Okay. Well, listen, everybody, I want to thank the panel for an outstanding session. I want to tell everybody on the line that a recording of this webinar will be available on the STS YouTube channel in a few days, so you can look it up, because I know some people said in the chat room that they wanted to ask that question, and I just want to thank the STS for allowing us to do this. It was very interesting, and I learned a lot myself. I also want to thank Pavan Atluri's workforce on adult cardiac surgery at the STS, because they're the ones who are sponsoring this. So thank you, Pavan, Dr. Atluri. And I want to thank the panel for joining us and giving us their input on these very important topics. We actually had an entire fourth paper that we didn't get to because we just ran out of time. So thank you all very much.
We'll be back.
And we'll sign out for the STS. Thank you.
Thanks,
Hey.
everyone.
Thank you.
Good night.
Joe and all the STS staff.
Thank you to Bavaria, and thank you to all our panelists today for your participation and insight. We invite you to become a member of STS if you're not one already. You'll enjoy a variety of benefits and opportunities to help you grow professionally, plus discounts on educational offerings like this course. Learn more at sts.org/membership. Delve into the extraordinary content from STS 2021 with annual meeting online, and get 360-degree views while luminary surgeons operate with the immersive video experiences. Each product can be purchased individually, or you can buy them together at a special bundled rate. STS members save even more. Learn more at sts.org/AMO-immersives. Please join us for the next 2 webinars in our 2021 series. First up on May 6th will be the topic Sedate or Cannulate, ECMO Strategies During COVID. 2 weeks after that, on May 20, we will be discussing the Resilient Surgeon, strategies to be your best self in and out of the OR no matter what. Thank you all, and good night.